Thank you. Good morning to everyone. And it is a privilege to have you in the valley. So I'm starting an RR as the patient who is a young female. She had an upper aortic calculus which was impacted, and we have just put a stent about a week back. So you can see the stent. Is there vision there? Hello?
Yeah, good morning.
Good morning, sir. Yeah. So this is a stent which has been put up 1 week earlier. So
a surface vision right now, so can we get the
just a minute. Oh, ये बात पाक पाक. Okay, sir.
we are getting it from the surface camera. Is the endo camera also connected?
Endo camera का शुरू. Endo शुरू. या दो में का शुरू है या ना आदि कुछ. या ना आदि कुछ तो ना हम यहाँ देने सुबह करो. मार दो. इसको बोलो यार. Urocon foi pagar isso, não é? O que eu te vi no canal também. Tá te olhando na rua. Ainda tem uma coisa de
I think you can proceed. We get a nice view from the surface also.
Okay, sir. Yeah. Okay, just for the time being. So this is the stent which we have put up 1 week earlier, and what we have seen so far, if you put up stent for 1 to 2 weeks, the orifice is good to visualize once you put an SS sheet. But if you keep it for 3 weeks or 4 weeks, then there's a lot of edema around it, and if you take the stent out, there's a chance that you will lose the aortic orifice, and then it's a problem to locate it again. So what we do, we just try to remove the stent with a cystoscopic. The stent is out.
How long do you recommend taking the trend?
The uterus. And the vision out. Now, what we do after removing the stent, I always go with the uteroscopy.
Voice is not very clear.
Yeah. So after this thing removing stent, I always go for the uteroscopy and see the ureter dilatation. How much is the ureter? How is the ureter? Because it is very important to see the condition of the ureter, whether the stent has adequately dilated it or not, or because I have seen some of the patients even put after stent, the ureter is not dilated enough. Yeah, it's a semi-rigid uteroscopy, and to see the dilatation of the ureter. Whether just once, yeah, exactly. Yeah. After seeing it, okay, is fine. So I will just put in guide wire. Individual go disconnect.
Sajjad,
Yes, sir.
What size sheath you will be using?
I will be using 10 by 12.
So can you use 12 by 14?
Yeah, you can use, but the chances of the damage is more. What I have seen, but I'm comfortable because I have the uteroscope, the flexibility that's about 8.5, and now the disposable comes 7.5, so you don't need to go within 11 by 13. or 12 by 14.
So in your experience, is there any difference between the rate of searches related to the size of the sheet? Like smaller sheet, do they have more infection as compared to the larger one?
No. What I have seen, injury to the glucose is more. But it's all the rest. It will be like that.
The mic is very close to your mouth.
Okay.
Voice is breaking.
Voice nahi hai. So you can see, it's clear now?
Yes, now it is better.
Okay, thank you. Now you can see we have put a guide wire. See his arm.
I think we need to get a clearer vision of the amount of
It doesn't know. Have you seen, sir?
Yes.
So this is the guide wire and the stone there. So this time I will now load the assay sheet. It is 10 by 12 with a section. Yeah, with section I will just show you on this. First I will just put it, just show this.
Just show us how the suction mechanism works. Sir.
Yeah, I will show you. See, this is assay sheet, okay? It's going.
Right.
So I will just take the guide wire and let out, and I will keep this suction catheter at least 4 to 5 centimeters below the stone, because to have the bend, natural bend of the scope. If you just put it with the scope will not bend and it will not have maneuverability.
You recommend placing the sheath, 4 to 5 centimeters below the...
Yeah, exactly, yeah. If it is in the upper ureter. If it is in the pelvis, in the stone is in the pelvis, still I will advise to keep the assay sheet at least 3 or 4 centimeters below, so that once the sheet goes in, you have the curvature of the sheet properly up and down.
Okay, sir.
So I am using the Olympus BR3. Olympus BR3. This.
So what is your preference today? Would you prefer the reusable scopes or the disposable ones?
I am using both, but the best till now we are doing the reusable scopes, because we have the steroid. We are doing this sterilization with the plasma. But disposables, once used, you have to use as a single use, which is not possible, because we are taking at least 5 to 12 cases if we use a disposable because of the cost factor.
Sir, are you using plasma to sterilize the this Olympus scope?
Yeah. We are putting it there.
Sir, we had a very bad experience. We had put it in the plasma, and by the time we took it out, there was like burning smell was there, like plastic burning, and we never, fortunately, the vision was not lost. We didn't use it again.
That must be the fiber optic.
No, it was digital scope, sir.
Digital scope, okay.
Yeah.
But it is not. So this is a stone. So it has, this was impacted, I think, here. Impaction was here.
Okay, sir.
So it has, after putting the guide wire, so it has pushed. This is the PUJ. You can see the PUJ.
Yes.
And this is the stone now in the pelvis. So it will be just that we will just start with the dusting.
So what is the power setting? Can you show us, sir?
Yeah, I am using by potent, and I am using 8 watts per energy gun. That is total of voltage of 8.
I think you need to adjust your mic once again. There is a lot of echo in between. So you said it's 8 joules and 10 hertz? Is that? No, I mean 0.8
Yes,
joules,
yes.
0.8 and 10.
Yeah. Total is 8, sir. Now we are now using a 200 micron fiber. So just get the fiber.
This is a holmium laser you are using, sir?
Yeah, it's a holmium laser. Come. Potent is a new company. What we are using here from the stores.
And this one is which company, sir?
This is a Potent. You can so this is a laser fiber. At 9 o'clock from this, it comes at 9 o'clock. So what we have, we will just start a dusting.
Ready, sir.
So we are starting here. In these things, the advantage is that the patient can be done morning and sent home in the evening of RIRS. And while doing this dusting, you have to be very careful because there's a lot of, you can see there's a lot of respiration excursions of the patient. So you have to be very, very careful about how to use it. So you also have to have your own respiration controlled as per the patient's respiration. And if there are more respiration rates, you have to tell the anesthetist to please decrease it to a level where the patient's safety is there. So we can just start the dusting like a painting, because outer core is always soft and it is the inner core. By this dusting, the all will come. See, here, if you go with it, there are some fragments which are then to see these fragments. They can go into any calyx. You start with, and you have to just keep the laser just near to the stone. If you just push it, it will fragment it. See the respiration moving of the patient, it will go up and down like a painting. So if there are any queries, I can just give if there's some questions. And if you keep the stent for a long period of time, sometimes there's this clot, it comes. But the only thing is that you just keep your cope for 2 or 3 minutes there, and then the vision will be clear. So if you see that before that the vision was not as good, now if I will just keep the scope just there without doing anything for 2 minutes, then you can see the vision, the clarity of vision, everything is there. That's the light can be. That's not light question.
लाइट इसका बड़ा
हाँ ज़्यादा नहीं
थोड़ा कम करो लाइट डिम लाइट
The other way is that if you want to do quickly, you can just fragment the stone into pieces and then remove with the basket. There's a lot of movements, respiratory movements. So you have to, was there's inspiration, expiration, you have to see when this laser you have to fire. So you have to fire not continuously but seeing. अच्छा बोझान था कि क्या? Am I connected to OT? किसी ना वही यहाँ था अच्छा इस पे तो क्या होगा हाँ ओके मैं क्या लाइक ऐसा करा मुझे कैसे पता चलेगा
हाँ सर
मुझे कैसे पता चलेगा आई वहाँ
एक आई एम यूगो सर
तो किसी को रखना इसको जो जो कोऑर्डिनेट करेगा और रिव्यू के साथ आप इधर मत रहो इधर हो ना आप आगे तो बोलो ना
क्या सर शन कनेक्टेड
So Dr. Sajjad, so what would be the size upper limit you will decide for your cases?
See, the best results are with a 1 centimeter stone.
Okay.
But if you are experienced, you can go up to 2.5. That's the only. But for a beginner, I will not advise them to go for more than 1 centimeter stone.
But Dr. Sajjad, you are having experience both with holmium as well as thulium. So is there any difference in upper limit of stone you think you will differentiate?
Actually, I always avoid holmium in ureter. Because sometimes, how much experience you are, whatever you are, but especially the patient, at that some point of the time, you may touch the glucosa. And the holmium is slightly more dangerous as compared to the holmium. So in ureter, I always go, my preference is holmium.
Professor Munir, your experience between thulium and holmium.
Mike, as I already said, the tholium is much faster and you can go for the bigger stones in tholium. Well, this apprehension that if it touches the mucosa and you get a stricture, I don't believe in that. We have been using the tholium the last 3 years. But only thing is that the strictures in ureter, they are because they are already impacted stone. The stone has been there for some time. And in case you use a tholium or the holmium, stricture may form. Only thing what you have to do is you have to have a good follow-up in these cases. And you call them regularly and you see the ultrasound and get it done. And if you think that the stricture is developing, then you can do a laser endopilotomy at that time. That is what we did in few of our cases. And they all are doing well. But you have to have a follow-up in these cases, in case they go into stricture formation. And also leave the stent longer. We leave it for a month or two longer in these cases, where it's in upper ureter.
So I'm going to ask you a question, Dr. Munir. You just mentioned that you need to follow up closely, leave the stent longer, and do an endoureterotomy. How many do you think you've had with thulium that you've required to do this?
Hardly you have 1 or 2. 2.
Okay. Okay. Because this is currently a matter of concern with the thulium fiber.
They say it generates heat and it does. It does, but not to that. You don't have to do continuously. Fire it, stop for a while, push some water, temperature will not rise.
Right. So the laser, of course, is good, but then there are some concerns about heat generation and about the strictures, and there is data to suggest that there is a increased risk of stricture formation, or whether it's technology or technique is something that still needs to be resolved.
But then also you have to evaluate the stone, how long it has been impacted. And those things you can't actually compare.
So the other thing which came out over the time, because initially the thulium came, people used very high energy settings to treat the stones. So over the time, the people realized that even with the smaller settings and all, you take more time, but you can really do fragmentation and dusting at a lower setting, and that cause less strictures as we are now progressing, and people are now fearlessly using this technology even for ureteric stones.
Dr. India?
Very right.
With very low
in all our cases we go for the
with very low settings.
tholium, yeah.
Hello?
You have to use the lowest settings possible.
Yeah, 6 jewels.
Yeah, 6 joules.
Am I audible?
Yes, yes, sir.
See,
Yeah.
this is the dust, okay?
Yes,
Fine dust.
very nice, sir.
Because I am using the fans, so I will just apply the suction, just apply suction, and see what is going to happen.
Okay.
This will get stuck.
Yeah, it's working very well, sir.
See, this is going, it's sucking. Then I will show you. So if you have a big stone, the dust is there, then it will be difficult. See the golden dust.
Dr. Sajad, do you really need to suck out the dust because dust anyhow will be coming out? So what is the real advantage of the suction
Yeah,
sheath?
the real advantage is, see, if there is a dust here,
Yeah.
I can see the stone properly.
Okay, okay.
So,
So,
if there is a dust, it will just be there and it will hamper me to see the stone.
yeah,
Is there or not.
sometimes
Especially-
you can miss a bigger fragment behind the dust.
And especially in the lower calyx.
Yes, yes, exactly.
Now I will show you, this is the Olympus. Now I will show you the stores, the new disposable Flex X C1. And then you can compare the vision and this thing, everything, okay?
Okay,
Just
sir.
like that. I will just take this one.
This one was the Olympus,
Olympus, yeah, Olympus,
reusable.
we
Now
have-
you are showing the stores disposable.
Yeah, now I will show the store disposable.
Both are digital.
Both are digital, yeah.
Javed, हपर खोल खोल ये पर भाई खोलता है पर
Dr. Rajiv, you have a variety of scopes available with you, digital and aims. So which one you prefer?
Scopes.
And how does one score? Scopes. You
So
do need a
scopes,
scope.
we started the standard way like everybody else. We started with fiber optic scopes. We used to use both Storz and Olympus. We shifted on to digitals once digitals were available. I found the digitals obviously had much better vision, but they were larger. That is standard. We are now using disposables routinely, primarily because we don't care as much about their breaking. Residents use it, less experienced people use it. But we don't use it as a disposable. We sterilize it again. We use them all at least 4 to 5 times, each one of them. And the vision is nice. So actually we are now disposable to a large extent. I use the fiber optic when I need a small scope. Specifically if I'm doing it in a child or without a sheath, then I'll use the fiber optic reusable.
So-
Otherwise it will be disposable.
So you can see it now, this is a digital new
Now
Flex X
this thing
C1.
7.5
Is that right?
it has come
Yes,
digital.
yes, correct.
So now I am
but we
using
have still
the
the,
stores. Flex X.
Flex X2, we still have one of
Show us the-
fiber optics.
They are showing the radiographic picture. Kindly show us the scope.
Hey, I will show scope. See the vision first.
We can see your fluoro image, a static fluoro image.
चला चला चला
Under vision हाँ है. Under vision.
विंडो विजन से
Show us the endovision.
काम मिलेगा ना stores का. चलो इसमें चेंज किया इसको under vision करवाना है इधर इसके. नहीं under vision.
In children, we just had a child a day before, about 9 years old, male, very small genitalia, and then, but we had stented it earlier with a nephroscope, and then when we took him after 10 days, I think, the P7 went in very comfortably. Even the sheath went in
Yeah.
comfortably, because you already scared that in such a, you can't push even a little slightest also, otherwise he'll land up in a stricture.
ज़्यादा मत रहो.
So, but we were comfortable and we were going to, we could do the stone, 1.5 centimeter stone very comfortably.
Right, so the general principles are that the ureters are not smaller in children. Ureters in children will accept a standard stent, a standard access, a standard guide wire. So we will typically put in a 6 French. But when you're putting in a scope in an unstented ureter, I would prefer a non-digital a fiber optic scope. If it's been sheathed, if it's been stented and I'm using a sheath, then it's really quite
we can
easy
see
to
now.
put in anything.
Point down.
The bigger challenge in a child is actually the urethra in a male child than the ureter itself. That's what worries me more at times.
Yeah, but the nephroscope, smaller nephroscope, you can put the,
Right. I prefer to use a ureteroscope to put in the
3.5.
stent, but that's okay. I usually use the ureteroscope to put in the stent. I have a 4.5 ureteroscope as well. So,
Sir,
but
now
that's
I-
okay.
I-
6-7
I-
Frenches should be okay.
Yes.
Please carry on.
I am not using the flex X.
Javed,
Yes,
Right.
surgical billiard.
Can you see some difference?
yes, it is more magnified than before.
And the vision?
Vision.
The vision is nice.
Nice.
They were both very nice actually.
Very nice. Even that one was good.
Yeah, fine.
So this is the Flex XC or something else?
Yeah, flex XC one.
So Flex XC, so it's
Yeah.
not disposable, it's a reusable scope.
No such as a disposable from car stores.
Disposable is also called Flex XC.
Flex XC one.
Oh, it's called the Flex XC.
C1. Yeah. It's a new one which has come by the stores.
Okay, because the Flex XC is their standard
Yeah.
digital
Yeah.
reusable scope.
Reasonable, yeah. But it's C1.
Okay, C1 is the disposable.
And what is the size of this French? What French it is?
9 French, sir. So for this 9 French, if you want to get the good results and the cope moments, you have to use 11 by 13.
So this is your opinion about sheathless RIRS?
See, I have done 2 or 3 in the children only, but not in the adults, because what I have seen in the of a patient, we have done till now more than 1,000 cases. We always see that there is ureter of the Indian, especially out here, they are not dilated. They are not, but you may get in sometimes, but very less. About if you have 100 patients, out of 100, 10 or 15 patients, you may go without a sheath. But majority of the patients will need a dilatation. And being in the government sector, or in the private sector, you can't afford to put the patient under anesthesia for twice. And once, for example, if you go and the ureter is not dilated, then you have to change the position and come the next time. So to prevent that one, we always stand the patient. And it is a good, very well. Reduce the time from 1 to 2 weeks to 1 week. So I have done an RRS patient who has stayed 4 days, 5 days, or 7 days.
Yes,
Okay, sir.
thank you. Warm sling,
To leave this, you are scope.
give me the
size 7.5 has also come now.
Yeah, that's an advantage. So the stores has a good vision, this one. Flex C1 no. But
Harmonic.
it's thicker and it's more expensive.
ये ठीक करना है
About the lack of scope.
नहीं मेरा जस्ट देख रहे हैं जी
Go for a sheathless with the
तो चलो शुड वी स्टार्ट
scope which has come now.
Yeah, but if they need to go, if you say in females, most of the time they will without the dilatation, without stenting.
फोकसिंग प्रॉपर है
Yeah,
फोकसिंग
that is what I am telling you. You may go easily within 10 to 15% of patients without any sheath. But
Females you can go, but in the males and robust males, young males is difficult. So I think we should all stent the young males. Otherwise, with the smaller scope, so you have given anesthesia, and if the 10 by 12 sheet doesn't go, then you have to have a smaller sheet, 9.5,
स्प्लीन स्प्लीन इधर
11.
and you can see the
And we use Fusen, initially we used those disposable
Yes.
Fusen ones, but it had, they have a time meter, 4 hours.
Lateral, eh?
And some of them did not even work for 4 hours. So we said it's better to have a CMC with the company, pay them if case they give you a standby. Supposing something goes wrong with the scope, they give you a standby and they take it for repair. And if you do, we're comfortable with the CMC and we have a digital scope.
then we
So we are ready with OT1. They want to speak to us. Can we have a shift to OT1, please?
अपना OT1 है
Can you shift the audio to OT1?
या गुड मॉर्निंग
Connect to OT1.
या गुड मॉर्निंग आर यू एबल टू हियर
Yes, sir.
Yeah, we are able to
Yeah,
hear.
yeah. This is 70-year female with complaints of hematuria for last 1 month, and they investigated and found to be a big tumor sitting on the left side occupying the middle and the lower pole. She is also having COPD, so we are likely to keep the pressure slightly on the lower side, and she is diabetic, hypertensive. So should we start?
Yes, please, let's get the endovision.
So we have established the pneumoperitoneum, we put the port, and we are ready to start, and this is a harmonic which I am going to use.
Dr. Baldev, this is Rajiv. Can we get your endoscopic view? Your laparoscopic view?
Can someone give the endoscopic view?
Kindly
Hello?
Yes?
Yes, Dr. Sajad.
Yeah, I have finished. See, this is the pelvis, okay?
Right.
So this is all got the dust which is here. So this is the pelvis. So this clean. Now I will show you this is the upper pelvis. With the small dust particle with this thing, so it will come out with the stem. Okay? So this is the another here with the pelvis. This is all dust here, dust particles. And I have all the way through. So now I will-
Sajad, beautifully done, very nice done.
so I will show you, I have to use the basket.
But with you were using a suction sheet.
Yeah, see, yeah, I use the section sheet, but
Why did you clear all this? It should have all been cleared.
so it's not going to get better. You will not get the clear.
That is the advantage of the thorium laser. It is fine dust and all is washed.
So these are dust part. I will not show you, but
Dr. Iqbal wants to have a word with you.
hello.
Hello, Professor Sajad.
Yeah,
Good morning.
good morning, sir.
Congratulations, it's a wonderfully executed program that you have got here. Having 3 screens and 3 surgeries at one time, it's a wonderful thing.
Thank you.
And the way you are handling this RIRS, it's an eye-opener for us. Congratulations again from my department.
Thank you. Thank you, yes, sir. So nice of you. So this is the clear, so now I will put a stent. Now, before leaving, I will just see the ureter. So ureter is absolutely, so the ureter is also safe, okay? Now I will show you what I will use the basket and I remove the other fragments. So I will show you how many fragments I have taken off to get it clear. And that is the beauty of this using the basket. So most of the people don't use the basket that's safe. So is it visible?
Yeah, we can see both your surface and the
Yeah, so see, these are the small stones which I removed from the basket.
Right.
From the basket. And it's clear.
Did you stay with your 0.8 and 10 hertz setting throughout, or did you change it?
No, throughout, because what is happening, I am just dusting the periphery of the stone face, because that's a very soft stone. And once you reach the core is very hard. And once you try to dust it, it will fragment into pieces. So I am always doing the dusting of the periphery first. Once you reach to the center, I'll just do the fragmentation and take this fragment with the basket without wasting any time.
सर लेजर करो इस बार
And this time, so the laser which I use, this whole room is from 30 watts. So I think it's a wonderful laser. So this, I am very much comfortable, and all of the stone is about 1.5 centimeter stone. It has been dusted easily.
So what is the highest frequency on this machine? What is the maximum frequency?
Its maximum is 20 hertz.
So the maximum is 20 hertz.
And 2.
So it will be 1.5 joules and 20
Yeah,
hertz if
sir.
it's 30 watts.
Yeah, 30 watt, yeah. Exactly, sir. So I think this is also a good laser. I used to it. So this is the first time I was using it. So this is the stone image. It was interactive. Okay, sir. So you can see
Right.
the
Very nice.
edema. So any question I can take, then I will leave.
No, I think you've done a great job. Everybody appreciates what you've done. Thank you so much.
Thank you, sir. Thank you. Thank you. Yes. Cross country. No, not that one. Not that one.
Can we switch theatres to Dr. Mallikarjun's theatre?
Collect OT3.
हाँ सर बिल्कुल लेफ्ट साइड में you can extricate better.
Hello?
Rajiv?
Yes?
Okay, what I did is I dissected the similar vesicles. I think you might be watching.
Yeah, we were looking at you.
case is 65-year-old gentleman. He is a known case of prostatomegaly, BPH with the refractory tension. He was on catheter. His PSA is normal, culture is normal, and prostate size is around 41 cc with a median lobe. So we, to save time, we have already completed our setup. So first we'll start with a cystoscopy. I hope endoview is there.
Yes, we can see that.
So this is the verum antenum. There we have prostate. Little bit of bleeding is there, and there is a median lobe side, and also cystoscopy is used to empty out the bladder. Now after this we'll attach a delivery device to the cystoscope. A standard 4 mm Karl Storz cystoscope is used. Right. We attach it. So this delivery device is used to deliver water vapors. So it has got 4 triggers and 4 pipes. So first one is this power cord which is connected to this generator. Second one is this pipe which is used to drain out the bladder. Third one, this one is for irrigation, and fourth one, this translucent one, is used to deliver water vapors. It has got 4 triggers. First one, if you can see, this one is used to retract the needle. The white trigger is used for irrigation. If I press it once, it will start the irrigation flow. If I press it twice and keep on pressing it, it will increase the flow, which is also known as turbo. There is another button, gray button, just behind this white. If I press both the buttons together, it will deliver the needle. This needle is used to inject the water vapors inside the prostatic parenchyma, and this blue one is used to inject the water vapors, right? So if we can see the endoscopic view, one can see the distal tip of metal and proximal end. So this makes one field of view. So one field of view is around 0.5 centimeter, half a centimeter. So we have to deliver water vapors after each 1 centimeter. So after every 2 field of view, we have to deliver water vapors. The diameter of this effect of water vapors is around 2 centimeters. So around a radius of 1 centimeter, it shows its effect. So we have to deliver it at every 1 centimeter. I'm going to start it.
सर
ठीक है ठीक है ठीक नहीं ये नहीं First we measure the length of the prostate. So this is one field of view. We start measuring from bladder neck. This is one field of view. Second, third, fourth, 5, 6. So there are 6 field of view. So it will require around 3 injections. We start it with the lateral lobe. We can choose either right or left. I prefer starting it from right side. So one field of view. This is one field of view. This is second. And just after we come proximal to it.
So Rohit, what we are seeing here, the vision is not very good. Is the irrigation pressure less or what?
Am I audible, visible?
You are not visible but audible only.
Okay. Can you see my X-rays?
You can, we can. Yes, sir.
Okay.
No, but we can hardly read anything.
So the first step is we have to see all radiological images put together on the screen and analyze what we are going to do. This is around 26-year-old female.
Okay.
She had bilateral stones. Left sided stone has been removed and BJ is in place. On right side, there is a solitary renal pelvic calculus, and these are the images given to me. Am I clearly audible? I will be discussing.
You are Professor Paul, you are.
Okay, like
Go ahead.
out.
Go ahead.
Now, as soon as the images come on the screen, you have to become an Arjun, and you have to concentrate only on your kidney, and this is my right kidney. If I start seeing these images, can you follow my artery forceps?
Yes, sir. Yes, go on.
The left kidney is seen here. Left kidney upper pole has started here, first, second, third, fourth. But there is no evidence of the right kidney, only you can see the liver coming over here. Fifth, still there is no right kidney. Sixth, there is no right kidney. Seventh, there is no right kidney. The left kidney is very higher up, and right kidney, the upper pole is seen for the first time in this film. Is it okay, sir? Hello?
Yeah, we are hearing it.
Okay. So this is the upper pole of the right kidney, which is from all around, it is covered with the liver, and these are the ribs. So upper pole is not approachable from the internal aspect. If somehow you have to approach the upper pole, you will have to go very needily through the sauce, through these erector spinae muscles. Anyway, this is just the impression. Number 2, 3, third, now you can start seeing nicely the upper pole. This radiolucence in the center shows now the calyx has started appearing. This appears a little dilated calyx with a small tiny stone, maybe just the Randall's plaque of the upper pole. Now if you calculate, you see the right kidney in 20 cuts. If it is seen in 20 cuts and it is a 10 centimeters kidney, there is every 5.5 millimeter, there is one image. And stone starts appearing in this cut. This is the 10th cut if you count from above. And you can see nicely dilated system, a huge kidney, and there is no rib here, no iliac crest, there is lot of subcutaneous fat. This is a female patient, so you can expect this much of fat. Now you see the stone is very medial and it is lower down. In about 11th cut you see the full stone, 12th, 13th you see. So in 4 cuts you see the stones. So it is somewhere around 2 centimeter stone, 18 millimeter to 2 centimeter stone. This is the extrarenal pelvis in which the stone is located. So now I have understood that I have to come somewhere in the middle pole and direct my needle towards the lower pole and towards the PUJ. No need to go for the upper pole. This much information I got from these cuts. And now if you see the plain X-ray, this stone is not seen. Although they mentioned that the Hounsfield units is 1200 units. At the same time, in these cuts, now coming to these cuts, you can appreciate this is the kidney, 12th rib is here, 12th rib is here, and this is the iliac crest. So there is enough area for me to enter. But at the same time, you see the colonic gas shadow on the lateral aspect. Can you see this colonic gas shadow?
Yes, sir. Yes, we can.
So colonic gas shadow now here, the hepatic flexure of the colon is just at the lower pole. From here, I am little more now comfortable that colonic flexure from here only it might be turning right side, turning to this side and going down. Coming back again to these cuts, I have to see the colonic gas shadow where it is. Colon, now I am planning to enter somewhere in the middle. Colonic gas shadow is not clear. Here is the colonic shadow. This is the colon. So near the middle and lower pole, the colonic gas shadow is lateral to the kidney, not not completely lateral and neither posterior, so it is not a retrorenal colon. Lastly, I will see the width of the pelvis I am going to puncture. Now this is the total width of the patient. She is a very obese patient. This is the total width of the patient. Total width usually is between 9 to 12 inches when the patient is lying down prone. So the stone is situated almost in the middle, this level. If you see from here to here, from posterior aspect, stone is almost 6 to 7 inches down. Okay, sir? This,
We believe that a DTPA scan has been done in this patient, and since the film showed delayed function, obviously expected, what was the percentage of function on the right side?
see a 26-year-old female with such a thick parenchyma all around, whatever DTPA shows, DTPA may be presence of the obstruction and maybe in the presence of infection. Even if the DTPA shows only 5 mm GFR, even then I will give a chance for removing the stone, removing the infection, leaving DJ for 2 to 3 months, and the function will recover. So in this case, I will not go for DTPA. I am decided I am going to do PCML. So I have not asked for any CT urography or IVU, just plain one thing more you can see is there is so much of abdominal shadow. So this is patient having lot of fat, and such females they have big buttocks also. So if I have to come somewhere in the middle and my point of entry is likely to be in this direction, I will be careful that I have to position patient in such a way that in the middle I can flex the patient on both sides so that the legs will go down. But in this case, I am planning to come from lateral aspect, crossing so much of subcutaneous fat, gerotas and going 6 inches deep. This is all I have understood by this. Now, when we started to pass ureteric catheter inside,
Are you audible, Professor Munir?
Sir.
You're almost taking the.
So I am telling you when we started to pass ureteric catheter, it was not possible because the stone was impacted there. So in that case, what I do is remove the guide wire and pass about 10 ml of saline inside. So that because these patients are dehydrated when they reach to OT and the stone is impacted, there will be edema. If you try to manipulate even a Torino guide wire, the straight tip guide wire will find its path outside the system. It may perforate. So always pass 10 to 15 ml of saline. It hydrates that area, flushes that area, and then when we tried to pass the guide wire went inside the system by the side of the stone, and it took a curve. So we understood that we are in the system, and then we threaded the ureteric catheter over that. Now I have positioned the patient prone. The Foley's catheter and the drainage is here by this here with and I have lifted the Siam as high as possible so that there is a good working distance for me
I have moved CM from 0 to 30 2-3 times to see that there is free movement. Now I have position, this is, are you able to put right there?
Yes, yes.
This is the marking of the 12th rib.
Yeah.
This is the 11th rib in the crest highest point. And now when I put the foot switch on, can you see the CM rib?
Yeah. No, we are not seeing.
The colon is same. Are you seeing CM rib?
Yeah.
Okay.
We are.
The colon is nicely seen. I don't concentrate at the time on the stone. My concentration is on the colon and the periphery. The colon is nicely seen on the lateral aspect of the kidney, where I am planning to puncture. So I will be extra careful. Now, give this CM 50 degree tilt. Just enough. This is the CM 30 degree. थोड़ा सा ऊपर That's all. We can see the we can see the colon surrounding the kidney.
Yeah.
Okay? And now you see the नहीं क्यों मत करिए बस वही रखिए जो रखा है हमने बस I have taken the CM with 30 degree tilt. 30 degree tilt. This is the इसको दिखाइए थोड़ा सा जूम आउट कर लीजिए तो पूरा दिखाइए मुझे भी इसको भी This image intensifier is hitting my head and X-ray tube has gone away from me. So my fertility is also preserved. There is a good working distance over here.
Okay.
The thickness and the paper, you can see my hair and the breath and on the abdomen, इस हाथ को दिखाइए दिख रहा है?
Yes.
So this is around 12 inches.
Okay.
I have seen the 12 millimeter even in 6 inches deep. Here is the texture of the line. So in the texture of the line, I will try to go straight. There may not be any angulation, but I will be watching the colon. So here I have taken this straight. Taken the middle and the CM. The scale is indicated with the tip of the. Now inject contrast, please. This is the time contrast will be injected first time. First 1 cc of contrast very slowly. If there is any extravaganation, I will come to know. It should be dilated double. Inject the contrast. It is nicely dilating only into the system.
Yeah.
The stone has probably came in the pelvic initial system, not at the PUJ. Right?
Yeah.
So it has got disinfected, size has reduced, stone has come somewhere here, so I can approach the stone in this way also now. There is no need because I don't need to go straight to PUJ in all many situations. So this direction will be good enough. So now I will tell this is ये surface बहुत अच्छे से दिखाओ अब. This is surface ये है. सर दिख रहा है नीडल?
Yes.
लाइट जलाएं कि काफी है आपको?
Yeah.
The light, this is all the space. Needle tip is organelle. This is the real press. I will position over here and my finger will be in the posterior auxiliary line.
Mic is very close.
ठीक है सर?
Yeah, you speak again. Actually, voice was not well with the bone.
Okay. So my needle tip क्या लिखा है? पहले CM दिखाइए. This is the direction I have chosen. Right, sir?
Yes.
This is the direction I have chosen. और now the surface view. The needle surface दिखाइए ये.
So this is how the angle is positioned. Only the patient is that. I want to enter 10-15 auxiliary level over here. So this one, I will come laterally over here.
So if you are going so oblique, the track will be longer one.
Yes, that is what. Now I will check over this color. Yes, that is going to be so long. That will be so long. So I will come a little closer and the long will increase. If I come closer on the pin from here to here, if I move, my angle will get worse because I have to get deep to that level. So now I should have a level to over here. Yes, this is what I discussed.
Dr. Pal,
Yes.
first get your audio corrected. We are not getting your voice at all.
I am repositioning, sir. Okay, now, sir?
Yeah, now better. Now you explain what you were explaining. You were taking that puncture laterally and you thought that there is the colon is in between. So how did you shift that and how now you will make the angle?
Sir, colon will come only when I go through the skin, subcutaneous fat, lumbodorsal fascia and muscles. Only then colon number will come.
Okay.
At present I am deciding the skin puncture. If I decide the skin puncture in the posterior axillary line,
Yeah.
and then I have to go with this angle because I am already, well, the back I am 6 inches deep.
Okay.
So if I go straight like this, I am likely to enter.
Okay.
If I reduce my angle as you suggested and I appreciated, because the length of track is going to be too long if I go from here.
Yeah.
So I shifted my needle puncture medially.
Okay.
And the same depth if I have to go, I will have to increase the angle.
Okay.
This is what I was explaining, sir.
Okay.
If I go more closer here, I will have to increase the angle to this level.
Yes.
So now I always follow a gradual descent technique because I want to enter to the convex border of the kidney.
Okay.
So I am trying to go from here, measure on the skin, measure on the patient's back, put the needle here. Yeah, this appears to be right distance for my plane to land by gradual descent technique on the runway. So here, if I see I am coming in the middle of the colon, but colon is far anterior, and now I will make a skin puncture. This area, I have made the skin puncture. This is the angle I have chosen because I have to reach 6 inches depth. With this angle, I am moving in and I am watching the colon. I am going towards the kidney, but I am watching the colon. Colon is not moving. So you can appreciate that.
That's right.
It's a jerky movement. Colon is not moving. I reach near to the kidney, around 1 centimeter from the calyx. Here I am touching the capsule of the kidney. Now the kidney should move. Kidney is also not moving. Now kidney started moving. Can you appreciate, sir?
Yes.
Kidney has started dancing to my tune, and now I will just make a puncture in this calyx. Now I will be going from 30 to 0 and keep watching the needle. Needle has moved laterally. भाई मेरे को करने दो, आप मत करो. Kidney, the needle has moved laterally.
Yes.
This is needle position in 30 degree, and same when I turn from 30 to 0, needle has moved laterally.
Yes.
This has shown me that my needle is superficial, back, posterior to the kidney. So what I will do, again position at 30 degree, take out the needle up to the lumbodorsal fascia, because track has to be straight. I will not try to niggle there, and increase the angle. Increase the angle Yeah, show that at the surface, how the angle you are increasing.
So this was the angle I was going in.
Yeah,
When I reached, I was posterior to the kidney.
okay.
So now I have increased the angle from the subcutaneous fat only. Now I will take again the same route, keep watching the colon. Colon is not coming on the way. Now kidney moves better. Angle is 5 degree more than before. I am feeling resistance at the capsule and now I have punctured. I am inside the system in 30 degree.
Yeah, yeah.
Turning from
See at 0 degree.
30 to 0. Still little outward movement but needle is there into the radiopaque area.
Yes.
So I will see whether I am in or not. Yes, I am in.
Yeah.
No, not this. J-tip guideline. So just by two punctures now, the first puncture was superficial, so increase the angle by 5 degrees, उसमें पानी नहीं डालना होता. I always use angiographic guide wire. Angiographic guide wires have J-tip Teflon coated and they were used for the vessels. They are so delicate. So they will not perforate the edematous pelvic system also.
Dr. Munir. Change to OT ball. Dr. Munir.
पानी डालिए ना नीचे से, पानी डालिए.
Dr. Munir.
इसके आगे टिप होगी, ये रखो.
Dr. Munir.
Sir.
Dr. Anil Alan says there must be some residual fragment.
No, there is no residual fragment, there is a stent there.
between a telescopic Teflon diameter and metallic telescopic diameter?
Metallic are 8. They are very much concentric one over the other.
Somewhere has created a version where I think he's got 2 or 3 steps. I mean,
They are good. The only thing is, if they handle it one over the other, means if there is a additive thing, then you have to replace the whole set. This set is 100 times it has been used. The Teflon telescopic diameter, they last long. Over this 18 French I am passing. This 18 French.
sir, I just saw something. The image for you is not well placed because you have to duck under the Siam to see.
Yes.
So even that has to be taken care of while we, because the monitor I think is not well placed for the surgeon right now. You are having to duck to see the monitor.
Thank you very much for taking care of me. It is not going through the lumbodorsal fascia easily. So what I will do, I will take out the whole assembly. Siam दिखाइए. I will take out the whole assembly out up to lateral border of the stone. Now अब ये दिखाइए. Now I know there is a margin of 1 centimeter. So now with both the hands, with the control movement, I will go 1 centimeter. I have gone through the lumbodorsal fascia. जो कटा नहीं था इस तरह से हमने उसको बाईपास कर लिया. And with the control movement through the muscle I am trying to go. Yes, I got the give way, but still there is lot of resistance. Yes. Now I have gone through and I see, now I see over here in the Siam, and every time when I have to make a control movement, I take it out the whole assembly, I take out by 1 centimeter and 1 centimeter whole assembly goes in. Again I take out 1 centimeter and whole assembly goes in. This much is enough. Now I must be inside, well inside the system. I have chosen this nephroscope, Olympus 22, and this one is 18. Next dilator is 24. So what I will do, I will dilate with 24, then remove that dilator and put a 22 implant sheath or straight 24 implant sheath inside.
So Dr. Pal sir, please ask the audience people to put your mic closer to your mouth, sir. They can just readjust it, sir. Thank you. Sir.
Hello.
Now, yes, you are audible, sir. Now, thank you.
So now again, this is a 24 French dilator. Same way I will be encountering resistance at 3 places. I will be going with control movement, give way, come back, go 1 centimeter control movement. Are you watching, Siam?
Yeah, we are watching you, sir.
Again, take it out by 1 centimeter so that the whole assembly does not go through and through.
Yeah, the idea is not to do a counter puncture on the middle side.
Yes. Now this has reached. This is 24 French. But now what I will do is remove the 24 French implant sheath. The dilator, and pass the 24 French implant sheath. So removing is done like this. Show. यहाँ surface दिखाइए. पानी डालते रहिए नीचे से continuously. The second dilator is pushed like this. Second dilator, are you seeing the needle?
Yeah, we can see that. You are trying to keep the inner dilator in place while pushing out the...
Yeah, while taking out the outer one. Taking out the outer one and the inner dilator is in place. In between I will watch. Yes. Inner is in place and the assembly, this one has come out. अब सीधे ही मुझे एम्प्लॉयड शीट दे दीजिए. Now give me the unplat sheet. Now this unplat sheet will go in easily because we have already achieved the dilatation. And as soon as it enters the pelvic calyceal system, I will start getting water from here.
Fluid from the edge.
I got the water from here.
Dr. Anil.
Now, this is the beauty of this guide wire. दोनों हाथ छोड़ दीजिए, सब लोग निश्चिंत हो जाइए. This guide wire is not going to slip away. This guide wire is not going to slip away. I am not so worried about this. I am just coiling this guide wire over here, this end.
Why didn't he? Dr. Pal.
Yes, please.
Shivam here.
हाँ
जी सर, नमस्कार.
नमस्ते जी.
नमस्ते. मैं कह रहा हूँ आप why didn't you put the implant sheath over the dilator only? Why did you remove it?
Another 2 French more.
No.
That he
Okay, so you could have used
to put a 22 French.
but you could have used a smaller diameter facial dilator.
जो dilator था उसका size वही था.
अच्छा, he didn't have that kind of a dilator. Okay.
Dilator, now this third dilator was 24. Over there the guide wire will go only 26. Sorry, the implant sheet. Only 26 French will go.
Okay, you didn't have all the dilators.
So that
I
is why.
have the dilators. But these are only 4, 12, 18, 24 and 30. So I used the 24 dilator, but I wanted to use the 24 implants.
नहीं, सारी sizes क्या आते हैं सर?
सब आते हैं.
दो फ्रेंच की difference क्या?
नहीं वो जो इधर है ना जो
Okay,
जो
fine.
है.
Okay, fine. Good. Yes.
Now nephroscope do.
Sir, can you go back to Dr. Munir for a minute? या एक बार आप enter. We'll first have the first look.
एक बार एंडो देख लो, फिर कहीं भी जाओ, फिर मत आना लौट के. फिर कुछ देखने को होता ही नहीं है, फिर क्या देखने को है?
नहीं वो तो तभी तो.
पर एंडो व्यू आपके साथ देखूंगा, अकेला नहीं देखूंगा.
बिल्कुल सर, इसलिए वेट कर.
अकेला नहीं देखूंगा.
Endo view from the PCNL theatre, please.
No cheating. Whatever I see, you will see. चले अंदर.
अभी व्यू नहीं आया सर.
अरे मुझे तो आ गया. बैलेंस कर रहा हूं, अंदर नहीं गया. जब आ जाए तो हेलो बोल देना.
Are we connected to OT2? Are we audible to you in OT2? OT2? We can't hear you.
Audio.
Good afternoon, sir.
Good afternoon.
Sir, we welcome you. Sir, kindly describe some brief features about the radiology of this patient.
Show the radiology. He is a 25-year male. He has a simple calculation in the right renal pelvis.
Fine, sir.
And he has been stented also previously, possibly. Initial plan must have been possibly RS, but we are taking him for a monitoric now.
Okay, sir.
So you can see the radiology. There is a stone in the renal pelvis. The size is around 20 mm. And you can see the dilatation of the right PCS, the lower calyx, mid calyx and upper calyx also. We have removed the stent and we have put in a U-cap and we will be planning a monitoric in this patient. So now if you want to regarding the puncture which side, this stone can be approached from all the three calyceal groups, superior, middle and inferior, pushing in the guide wire stents and other things. It won't be that convenient and there is no need to go to the superior calyx. So we'll be planning through the mid calyx, the posterior mid calyx that we see after putting in the contrast. So that is our plan.
Thank you, sir.
Good afternoon, Dr. Arif. This is Dr. Anup from Delhi.
Sir, good afternoon, sir.
So we are eagerly waiting to watch your excellent surgery.
Sir.
Thank you.
Can we proceed?
Yes, sir.
Please.
Thank you.
I'll request the chairpersons of this session. May I have the honor to invite Dr. Shivam, sir. Sir, kindly come on the dais, please. I have the honor to invite Dr. Tariq Mir. Sir, kindly come on the dais. I have the honor to invite Fawad Siddiq. Sir, kindly come on the dais.
So, this, if you can see the surface, patient surface, camera here, yeah. So this is the 12th rib, this is the 11th rib, this is the posterior axial line, and this is our spine. So patient is in the prone position. If you can see that this is the stone, show the CRM, show the flora, yeah. Now we can push in the contrast, Yeah, this. Yeah, we can see the contrast, yeah. Pushing the contrast, keep pushing. Yes. You can pull it a little bit. You can, it's supposed to be, that's true. Minimum. Light. One is posterior light here. Put in the contrast, so this one will come. This is better, you should here. This is our posterior calyx in the middle calyceal group, and we will be planning our puncture, and we can see the 30 now. Give me 30. CRM 30. So this is our 30, and this is our, we will be planning the bullseye.
Dr. Said. Dr. Said is there. Arif. Dr. Arif? So are we connected to OT with Dr. Arif?
Are we audible to you?
Yeah.
Yes, Dr. Arif, good afternoon. Shivam.
Good afternoon.
Kaise hain?
Badhiya sir, all good.
Okay, thank you all for your hospitality and
Thank you,
everything.
sir.
So, tell us exactly how did you identify the posterior calyx?
Yeah, sir.
Yes.
So this one you could see the, when it is the contrast, we could see the lighter contrast, that is the posterior
Okay.
calyx, yeah.
Right, sir. So one of the ways is definitely what you are saying.
Yeah.
Another thing that we usually often use is a double contrast.
Yeah, that's a
Yes,
double
yes,
contrast,
right.
true, sir.
So that makes it even more clearer.
True, sir, true, sir, true, sir.
Right.
Yeah, so you can see. So you can see the flow.
No, we are not able to see
See the flow.
open view, yes. Yeah,
The flow is there, sir.
yes, perfect.
Thank you,
Wonderful.
sir. Thank you. Now push, we will be pushing the guide wire now.
Right. So this is a Terimo guide wire, right?
Yeah, Terimo guide wire.
Terimo. So you usually prefer Terimo?
Terimo, sir.
Right.
थोड़ा सा बोलना वैसे हाँ मैं डाल दूँ
So let us see the Siam view also.
Siam you can see
So
sir.
can we have the on
And,
PIP? Siam on PIP or?
You get थोड़ा बाहर से मैं बता रहा हूँ
Right.
थोड़ा सा we try to push into the
Kindly try to put in PIP mode.
So that we can have both the views.
We can see both the waves.
yeah we can park in little bit it has gone down
Yeah,
you can see
yeah. So this will straighten up also
this
if
will
you just
straighten
want
up
to.
after-
Yeah.
this is sufficient sir we are inside so give me contrast little bit.
So how far have you gone in the ureter? Is it just partially or it's into the bladder?
We have to check to the floor then, but I would like to straighten it after we take the needle out
Right.
on the guide rod. Okay?
Okay.
So this is a puncture we are making here with the limit for a floor. Maybe नहीं चाहिए. ठीक. Now let us park it nicely then. This is
So
out.
can we shift to OT with Dr. Rajiv Kumar? So he's almost finishing.
Please,
Shift to
adenoidectomy.
OT3. Shift to OT3.
Rajiv, Dr. Rajiv, Shivam here, yes.
Hi, good to hear you.
Yeah, great. We are saying just almost done, right?
Yeah, we're almost done.
Yeah.
There is this.
So your voice is a little faint. Can we have a bit louder voice?
मेरी microphone.
Yeah, this is better.
Okay.
This is better.
So we are actually quite done. There is a. This is
This is the stone. This is the stone. Lithoplast. No, so can you see the stone, sir?
Yeah, definitely.
Yeah,
The stone
okay.
is,
Who's the football?
on Siam we can definitely see
Yeah.
the stone.
As you rightly said, it's better to always to straighten the guide wire, but
Yes, yeah.
before I was planning, they had made this harm away, yeah. So
Okay.
it can be done, sir.
Doesn't matter.
That is always a better way.
Yeah, you while putting the nephroscope, you can always straighten up the
yeah.
guide wire. That's right.
What is it? Footpad में सीधा दे दो, footpad सीधा दो. मेरे ख्याल में इधर से
Now, for the
देख रहा हूँ
benefit
ना.
of the residents, yes, I think straightening the guide wire is very important before dilatation, because many a times you would not be able to dilate if the guide wire is not straight. Secondly, it's always better to put it in the bladder, the guide wire, so it remains very stable, right? Always. Otherwise, it may come out anytime. The Terimo guide wire is very slippery, hydrophilic, so it may come out.
Here was the endo view, OT2.
Can we keep this in the PIP mode and then have the end of view? Yes.
Intra-abdominal pressure 5 करवा दीजिए.
Yeah, see, we are fragmenting the stone, you can see, sir.
No, we are not having the end of view.
Okay, show the envelope, please. Envelope दिखाओ.
अच्छा.
You are almost fragmented, sir.
Okay, we can see the sound of litho. We can hear the sound of litho, but not see the.
That's the guide wire there, okay, they can show you.
नहीं, लग तो रहा है कि टूट रहा है. Yes.
नीचे से पानी जो we want to get the fragments out. No, ये आ जाएंगे पानी के साथ.
Show us the endo view.
Camera person, please the end of view, please.
Show. This is in the these are the fragments. No. एक मिनट थोड़ा इसका प्रॉब्लम.
पे scissors पे किसी भी चीज पे करो.
पता है? चलो
45 भी दे दो. 45 वापस दे दो.
पानी तो आ जाए.
पानी दे दो और ऊपर से पानी.
पानी से दे दो. माँ का बच्चे ये क्या सुधार थोड़ा सी. ओके. अतरा वो वायर दे अगर जरूरत हो.
चलो ये तो क्लास है थोड़ा सा.
हाँ इसको तोड़ देते हैं ये वाला. या फोर्स से भी दे सकते हो.
Okay. So I think yes, we are able to see the stone. They already fragmented and they are trying to come out. Yeah.
And for this time I have removed the guide wire.
Okay.
Because otherwise they would
Right.
hamper the passage of this. आप पुश करो नीचे से पानी पुश करो. Yes.
अच्छा, पुश करने से ही बाहर आ गया. Wonderful.
So these fragments I have already fragmented. They are coming out. We will be checking here also.
Yeah, I think this is almost done. Arif has done within a couple of minutes probably.
This is their capability.
Yeah. So can we go to Dr. Kandap's OT now? Just
OT1.
waiting for it.
Let's go to OT1.
So Dr. We are not getting your voice, Dr. Kandap.
Cautery चल नहीं रही.
Yes. Yeah, we have two more chairpersons with us, please.
Good afternoon, sir.
Yeah, good afternoon to everyone.
Yeah.
This. You can see the end-on puncture. This is our the puncture side. Yeah.
Yeah.
You can see again. This is directly posterior calyx and directly aligned towards the POJ. This is again. You can see our ducat.
Yeah.
Take a fluorokite. They come with.
So you did with 24 Amplache? What was 18? Mini perk. Wonderful.
Give me a fluoro shot.
Yeah.
You can see nothing here. Nothing. Show again, fluoro. Nothing. We'll again have it. पानी दो ऊपर से. पानी दो शाबाश.
You can move your Amplache, and that will even better tell you if there is a small residual stone.
True, sir. We have done that.
Yeah, yes.
There is nothing here as such. Anything is here. There is nothing here. See again now.
Now, I was talking about under C-arm also. You can move your Amplache and see. Yes, that's right.
Show me the sheet. Fluoro.
Yes. So if there is any stone, it will move with the kidney. I think that's done probably. Yes. So Dr. Arif, anything else you want to say? Yes.
I think we are done with this.
We are done. You would like to put a stent, right?
Yeah, I would like to put in a
stent. And a tube? No.
No tube, sir.
No tube. Right. Perfect. Perfect.
Yeah.
Arif sir, good afternoon sir, Fawad here.
Yeah.
Sir, I would like just to comment on, sir, you used the flushing from the very beginning of the procedures to flush out fragments. Is there any worry? I mean, the fragments in the if we flush in the initial part, they might dislodge initially because you have already fragmented the stone and we're giving.
That is always the risk, but we will, before completion, we'll do a good nephroscopy. If they have moved to any part, they will come back and we can retrieve them through the track only.
Okay.
But too much flushing, the one more risk is the risk of sepsis and all that. We have to be a little bit careful about that.
I think you wanted to say that it may go into other calyces also sometimes these fragments.
We can still flush them out from there.
Right. So
because in this, we're using a smaller shape, so it's not advisable to remove all the fragments by the forceps and all that. Most of them come out with the flushing only. Sir.
Yeah. So most of the stones were in the Amplache.
Yeah.
So he used it so that it can come out.
They all the time, so mouth of the Amplache at the bulk of the stone bulk and so that they can come out. Yeah.
Right. So Dr. Arif, we often in this kind of cases, we have 3 types of super perk now. Where we have a suction device and all
those
and
things,
they are so wonderful.
Wonderful that you
it's
did.
beautiful device and we have stopped doing
yes.
these mini PCNs
exactly, sir,
after that
exactly.
super perk.
Exactly, sir.
Yeah.
Thank you, sir.
Thank you, Dr. Arif, for a wonderful demonstration.
Thank you, sir.
So, a big round of applause for Dr. Farid. Thank you. Let's go to Dr. Kandan.
OT1, please. Shift to OT1.
Who else is there on the panel? Who else is there on the panel?
Shiva.
Give me a three. Don't we get my credit? No, system was set. Gentlemen, kindly show the screen. We are supposed to show up. Show the screen. So you can get it's a okay. I've never heard this code before, but I'm sure it's a good code. Chalo. Give it a watch piece. Just do a right there. Chalo now. Okay.
He's almost finished now. और फिर आप इसको हिट करोगे चला जाएगा
Okay, now can okay, now one second.
ये जो है ना हाउस
What is this? Push him.
हमारे की सर्कस का
नहीं होगा तो डबल जो डाला था अपने बिहार से नहीं किया ना यूज नहीं लाओ डिजिटल पीछे you put more in you can do it small it's cool right so much money is one that you can get the whole can you go back to focus करो shoot Siam shoot and make it okay possible. The size of the stone is 1.2 centimeters and the HUD is 1800. Scope size here. Scope size is, no, the scope size is 8.4. Plus करना थोड़ा और. And what the size of the sheet? The size of the axis sheet is 9.5. 9.5 है ना? This is the axis sheet. 10% in the diameter. 10.7 in the diameter. 10.7. If during dusting it does not dust properly, then I prefer to fragment and then dust the fragments. I do not like spending too much of time in a RARS, and I do not want to do a lot of pressure, lot of... I like the concept of the pressure monitor in the scope. I just use Kadam pilot using, and I think it's a nice thing to do. As Kadam rightly pointed out, that you don't want a pylon lymphatic backflow, and then the patient with an infected stone, not always with infected stone should be in the cultures, then we can go into. Okay, that's it. This was tempted, but I don't know what, Fleshko, I don't, this was tempted, but I prefer, I do not always tell, but I do tell the patient that if I am not able to, if I find the ureter not very pliable, then I will do the stent. In private practice, patients don't like keeping stents. The only advantage of a stented thing is after you have done your RARS, then you don't have to put the stent back again. You can wait for the retrograde catheter. The two things which are very important as far as agriculture and the rest, Karnataka has explained so beautifully, is one, the type of the mucosa and that you have, and the sugar you can really explain mucosa and pliability of the ureter. I always pass a rigid scope, small one in the ureter before but of course in this patient it was stented, I'm sure these boys must have done the ureteroscopy to make sure there's no ureteric stain. So in my opinion, the most important thing in the ureteroscopy is not the fragmentation of the stone, but is the ureteroscope itself. Don't ever break a ureteroscope, don't do something which is, treat it. The ureteroscope is an instrument which can get broken if you've done it too much. There was also a case recently I was told where the access sheet will not come out. Now if the access sheet doesn't come out, you can take out the outer covering because sometimes people have a thin wiring there, and then, there we are, flush cover. Make sure you always see the tip of your laser fiber as you please do laser. This patient I will give the digestion because the H units are very high, and also because I'm not, and it's a very hard stone. If the procedure has gone off very well, I keep it for 2 weeks. If I had a problem with the procedure, I keep it longer. If I do a non-contrast CT scan before I remove the double-J stent, and if the non-contrast CT scan tells me there is no fragment appreciable, I do not do a look ureteroscopy.
What we are going to do is,
removal of DJ stent.
Jalwa? Don't increase. Huh?
That is a good idea to actually prevent a patient from coming back and being upset about residual stones, because when you remove the stent, you can do a repeat RIRS. So that's a strategy to reduce your own headaches.
I carry on fragmenting till I find out that my X-ray, my Siam does not show me a significant fragment.
Can I increase the power?
Yeah, please increase the power.
Hold it.
Still a good number of patients require 3 procedures. Pre-stenting, then RIRS, and then relook RIRS.
That is coming from a percutaneous guy.
Okay, here I must confess, I was always a percutaneous man and couldn't help it but start doing RIRS, and I said couldn't help it because I was very happy with my PCNS, but it was the order of the day, the patients wanted it, and now I don't regret having learned RIRS.
So is there a rule of putting integrate some needle for the drainage if the vision is not clear or you are expecting a time consuming stone is large and you are expecting more time?
I beg your pardon, sir?
Integrate placement of some needle and then it will decrease the pressure and then your vision is not good. Is there any rule of putting that needle in the integrate and doing the RI?
There's a lot. I have not had that thing because once I see a lot of bleeding, I rather go back in rather than carry on doing RIRS and a bleeding. There will be some little bit of in hard stones. Now I have patients who had double J stents put in, and because of the double J stent itself, there has been a little bit of trauma.
Sir, what's the minimum time that you keep the DJ stent before proceeding for RIRs in a patient?
If I do a pre-stenting, then I keep it for 2 weeks. There is no point keeping it for 2-3 days.
So in 2-3 days time, the ureter dilates to the extent
I know, I understand.
RIR.
Sometimes I keep it for 7 days, but like I said, most of the time I'm not doing pre-stented.
Sir, we'll be back with you. We'll just shift to OT1.
Okay, this is going to be a hard stone, so I have to keep at it.
Connect to OT1. Hello.
Hello, sir.
It's quite clean actually, but we got very hard fragments. ठीक है ना? और करना है? Yeah, flash please. Yeah, I think so.
Frequency comes.
Frequency comes, okay.
Focus on the stones, they just fly here and there with that much frequency.
क्या? Frequency कम क्या? चलो.
8 hertz here.
Sir, if your patient is not pre-stented, do you always put a stent at the time of RIRS or?
That I do always. I always put a stent after RIRS if the patient is not restented.
What complications have you come across? You must have a lot of experience doing these RIRS. What complications have you come across? Just share your.
Oh, I've had my complications. The worst complication I've had is carrying on for over an hour and the patient going into septicemia, number one. Number two, I had my guide wires not coming out and I had to go back with the rigid scope to take them out. One of the complications we had was many of the fragments had gone in the lower calyx and we could not able to get to the lower calyx because those days we never had those thinner scopes. Now it's easier to get the lower calyx, but when we had these earlier thicker scopes, they would go sorry. Flush. नहीं. Frequency कम किया. Can I have a Siam please?
Siam shot Manzoor.
बस.
Siam shot taken.
Flush.
Sir, what are the antibiotics that you use for prophylaxis in these patients?
I use cephalosporins.
Which class or any particular
I
cephalosporin?
normally use Supercef. But however, if the patient has had an infected urine and a stent for a long time, if they come to me, then I use the meropenem. For me, I consider RIRS to be a procedure which can give you much.
You have done a urine culture. What's the organism that you usually grow? E. coli or sometimes Pseudomonas, something like that?
I am scared of Pseudomonas. We normally get Pseudomonas.
So, Pseudomonas will not be covered by cefuroxime.
No, but then we give meropenem or piptas.
Straight away, okay.
Yeah. You see, in spite of me using it for so much of time, there's hardly any dust coming out of this stone. It's a very hard stone, 1800 H units, and frankly, it is 1800 H units. I wish I had that suction, which is here, but I'm using this scope for the first time, this axis sheet for the first time, and the homium for the first time. Chalo, this homium. You know, I might take a basket later, but let's see. हाँ ऊपर बट ये देखो ये बट आई कांट बट स्कोप तो अंदर ठीक से जाता नहीं है यार ये स्कोप जाता है इसी आई डोंट नो Flush. 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 Hey, flush. हाँ उसका सामने रहा it's not broken. There's a leak from your एक second. The first flush करो. See if you can flush it out of that very calyx. Any other suggestions? Hello. Flush. Take a breathing rest, please. Flush. What happened? काफी हो गया ना? फ्लश करो। सियार में पूरा दिखता है? ये सियार को जरा फ्लेवर फ्लश करो। फ्लश। It's now quite powdered. Can you hear me? Can you see it?
Yes, sir, we are seeing.
Siam, huh?
Yes, sir.
It's quite powdered actually. I don't want to do much more. Show down. Flush. Huh? I think it's quite powdered. Show the Siam, please. Siam, dikhao. Show the Siam. It's quite clean. There's nothing there on the Siam. Is that okay? Chalo, flush karo. Anybody wants to fragment more? Dust more? In the audience, everybody wants to dust it more? Anybody wants more dusting in the audience? Because if I look at the Siam, it's totally clean. There's nothing seen on the Siam. Flush, please.
This is duodenum. This is IVC. This is IVC, and this is gonadal. So you need to go into this plane.
We are not getting an endo view from OT3. Rishi is doing a pyeloplasty. So yeah, Rishi, we can't see your laparoscopy view. So somebody needs to give us the laparoscopy view.
Can you have the end of view?
Connect us to OT3.
Laparoscopy view from OT3, not seen.
Kindly connect to OT3.
Hello, audiovisual team.
Okay. Hi, Dr. Raina here. Now the WJ stent has been passed. I passed it around the Siam without pushing the camera, etc. in. Now the thing is, this is the scope I used. No. It's a Chinese scope. What's it called?
Future Med.
Future Med. The laser is a Holmium laser potent.
Future Med.
It is also made by a company called Future Med. It's a digital scope.
That is.
Now the scope is actually 8.5.
8.4.
8.4.
Yes.
So
We have 7.4 also.
You have 7.4 also.
7.5 also. That one.
Okay. Fine. It's not a bad scope. The vision is okay. Yeah. Okay. I am normally used to using X5 torch, or I'm used to using the Olympus scopes. And on my laser, I normally do ureteric stones. For RIRS is the thulium. For ureteric stones in the ureter, I use the holmium. Thank you.
Robot laser, sir.
It's a good laser. It breaks well. Thank you. Okay, and the Siam, you see the Siam picture, the stones are quite, Siam is clean. So these are all small fragments. But you couldn't dust it because dusting would take a long time, and it's a very hard stone.